2013, and we are proud to be the first Indian aesthetics company to be listed on NSE Emerge, offering over 150 plus SKUs across aesthetic and medical dermatology. Building on this strong foundation, we are now proud to bring MeLine, a scientifically advanced, result-driven solution for melasma management to the dermatologists across India. And what a better day to celebrate the science and art of dermatology than today, the National Dermatologist Day, a day dedicated to honoring the incredible work that each one of you does every single day in transforming lives through skin health. Wishing each one of you a very happy National Dermatologist Day. It is an immense pleasure to welcome each one of you to today's event, Melasma Management in Indian Skin, the need for a customized approach with MeLine. Tonight, we have an exceptional lineup of experts from across the globe and across India, bringing together international scientific expertise. Our speaker for the evening is Dr. Ana Morales-Galligan from Spain, key opinion leader for MeLine. On our panel tonight, we have Dr. Ameesha Mahajan from Amritsar and Dr. Pallavi Ahire from Pune. And leading through this incredible discussion as a moderator is the distinguished Dr. Neeraj Pandey from Lucknow. Dr. Neeraj Pandey is the founder of Derma Clinic Lucknow and a respected name in the aesthetic and clinical dermatology with over 15 years of practice. Dr. Neeraj brings the perfect clinical lens to steer tonight's discussion. We are truly honored by the presence of such a distinguished gathering of experts in the field of dermatology, and we look forward to a deeply insightful and clinically enriching evening ahead. With that, I now hand over to our moderator for the evening, Dr. Neeraj, to take us through this exciting discussion. Over to you, Dr. Neeraj.
Thank you, Melanie, for such a warm introduction. At the outset, let me thank Aakaar for bringing such an academic event. And today we are honored and blessed by the presence of Dr. Ana Morales-Galligan, who will be the star speaker for the event. And she'll be speaking on melasma and Indian skin and predominantly on the MeLine range. And she's a dermatologist from Miguel Servet University Hospital, Zaragoza, Spain. She is Associate Professor of Dermatology in University of Zaragoza. She is key opinion leader in Aesthetics. She is specialist in medical surgical dermatology. She is member Spanish Academy of Dermatology and Venerology at AEDV, and she is corresponding academician, Royal Academy of Medicine and Surgery of and recipient of Juan de Azua Prize, that's AEDV, and expertise in pigmentation disorders and aesthetic dermatology. And we are also blessed by the presence of Dr. Ameesha Mahajan, a renowned dermatologist from Amritsar. She is Vice President of IADVL Amritsar chapter. She is aesthetic dermatologist with expertise in pigmentation management, and she has a special interest in chemical peels and aesthetic procedures. And Dr. Pallavi Ahire, she is consultant dermatologist from Pune. She has strong academic background with presentations at various international and domestic platforms. She is into her research interests include reticulate pigmentation, keloids, and it's a long list. And the other esteemed panelist today is Dr. Bharti K. Patel. She is aesthetic dermatologist from Mumbai. She has over 15 years of clinical experience. An area of expertise is mesotherapy, facial aesthetics, laser, and so on. With this, I'd like to invite Dr. Ana to start her presentation. Over to you, Dr. Ana. And now you can share your screen. Thank you.
Okay, thank you very much for your presentation. So let's start. Okay, so can you see it properly? Is it okay?
Yes, we can see it.
Yeah, absolutely, absolutely fine.
Okay.
I can hear it also and see it also, not an issue.
Perfect, perfect. So let's start. So my name is Ana Morales. I'm a dermatologist from Spain. It's a really pleasure to share with you this evening this interesting topic. So we're going to talk about a very, I think, very special brand because it's different from other brands as it treats specifically every type of hyperpigmentation. And it's special for two reasons, because it has treatments, different treatments depending on the phototype, on the type of skin. And it also is different to other brands because we act over the hyperpigmentation in all the stages of pigmentation. In the pre-synthesis of melanin, in the synthesis of melanin, acting over the tyrosinase, and after the synthesis, in the post-synthesis. So that's why it's so different, and so it's a so good brand and it has very good products to treat hyperpigmentation. So let's go on with our presentation. I'm going to do a brief introduction about pigmentation because I think it's very important to understand how our skin pigmentates. So we know that in normal skin, the melanocytes are located over the basal membrane, and their dendrites are projected into the epidermis where the keratinocytes are. So one melanocyte is associated around 30-40 surrounding keratinocytes. And this entire unit is referred as the epidermal melanid unit. There are three elements that are crucial in the pigmentation, in all the pigmentation. First of all, we have a crucial enzyme, which is tyrosinase, which synthesizes the melanin. Then the structures where this melanin is synthesized are melanosomes. And then we have some trafficking proteins, which are really important to transfer this melanin to the keratinocytes. So this is the melanosome that is inside the melanocyte. And here in the membrane is the key, the key and the important actor, which is the tyrosinase. It is the key regulatory enzyme that orchestrates all the melanin biosynthesis. It's here embedded in the melanosome membrane, and it has an essential cofactor, which is copper, to produce the melanin. So here is what's the function. It's the conversion that is catalyzed by tyrosinase. It comes from L-tyrosine to L-DOPA, and this is really the rate-limiting stage in all melanin synthesis. So what happens? This is the normal skin, the healthy skin, where the tyrosinase produces all the melanin, the eumelanin and the pheomelanin. But in some diseases, for example, in albinism, there is a tyrosinase doesn't work properly, so we don't have pigmentation. So that's why tyrosinase doesn't work and we have the albinism. So let's see how the melanin is synthesized. We have several steps. The first step, the melanosome is an organelle that is produced in the endosomal Golgi system. And when this melanosome is mature, it produces, thanks to the tyrosinase, it produces the melanin inside. And this melanin, when it's mature, it is transferred to the keratinocytes due along the long dendrites that are gone to the keratinocytes. And finally, the melanin is transferred to the keratinocytes. So that's when we see the visible darkening of our skin. But what happens when we have pigmented disorders in our skin? There's not only an alteration in the epidermis, it's demonstrated that the basal membrane is also damaged, and it's characterized by interruption gaps that thin the dense lamina. So the melanin goes through the dermis, goes down through the dermis, and this melanin acts like a foreign body. So this triggers all inflammation, phagocytosis, and all the inflammation that you can see here. This is like a summary of how does the alteration of the pigment appears. We have some aggressive factors that the most important, of course, you all know, is UV radiation. So when the membrane is damaged, this melanin, as I told you before, gets into dermis and it acts as a foreign body. So there are a lot of inflammation mediators that are released and start all the inflammation, and the pigmentation starts again. So as you can see, it's a vicious circle that we have to stop. And that's why it's so important to avoid all this inflammation and, of course, avoid sun exposure, but also all the inflammation that sometimes we don't think about it. And it's really, really important to stop that all that circle. So this would be all the triggers that influence in hyperpigmentation. Of course, in women is very important, all the hormonal influence, pregnancy, menopause, this increase of the concentration of melanotropin induces the tyrosinase to work more and induces the melanogenesis. But also other factors, all other inflammatory factors, as I told you before, burns, scratches, acne, any inflammation in the skin is going to stimulate the tyrosinase, and we're going to have more pigmentation. And of course, all free radicals that act as inflammation triggers too. So these are all the causes and all the triggers that are going to stimulate the pigmentation of our skin. And how does this manifest? Well, the manifestation of all this is, of course, the post-traumatic hyperpigmentation, which we will say PIH, and is a visible consequence of the several cellular disruption, inflammation, and we have a lot of causes. One of it, I want to focus on this because we have to be always very, very mild and very kind with our peelings, because we don't want aggressive peelings, especially in ethnic skin, in more pigmented skin, because it's a high risk of hyperpigmentation, post-hyperpigmentation. So it's really crucial when we are treating hyperpigmentation, we are treating melasma or other pigmentations, it's really important to know how deep is our pigmentation, because the treatment is going to be different. It's not going to be the same if we have a superficial pigmentation or a deep pigmentation. So, and how can we know if the pigmentation is superficial or is deep? When it's epidermal, usually it's a dark brown color, and if we use the wood lamp, we can see that it becomes brighter under the wood lamp. And it has a positive prognosis. When we treat this epidermal prognosis, it has a better prognosis than deep pigmentation, than dermal pigmentation. So when we have dermal pigmentation, the borders are unclear, the pigmentation is like gray, light brown, bluish sometimes. And if we examine it with the wood lamp, the pigmentation doesn't change. So that can help us a lot, the examination with wood lamp, to know if it's a epidermal pigmentation or a dermal pigmentation. And of course, we can have mixed pigmentations. We can have dermal and epidermal in the same patient. So these are examples of, in this case, this is an epidermal hyperpigmentation. As you can see, when we examine it with wood lamp, it comes darker, and the pigmentation comes darker. Whereas when we have dermal hyperpigmentation, as you can see here, is like a more gray hyperpigmentation. And when we examine with wood lamp, it doesn't come up, it doesn't bright up. So it's easy this way to differentiate epidermal hyperpigmentation than dermal hyperpigmentation. And of course, as I was telling you, we can have both mixed hyperpigmentation, dermal and epidermal, in the same patient. So what are the main steps of treatment now that we know the triggers, and now that we know how does the pigmentation produces? Of course, UV protection, as we saw before, is one of the most important triggers for pigmentation. So our patients always have to use UV protection. And we'll have to use professional and home treatment with ingredients that inhibit melanogenesis, of course. And we have other tools such as exfoliation treatments, antioxidants, and deep hydrations. So the ideal and the important treatment, key treatment, is to do a multifactorial approach, because all these steps are crucial to be effective in our treatment. So now let's start with our products, with Beeline products. As I was telling you before, they are really special products because they are very complete. We have different products that we'll see now to treat different types of hyperpigmentation according to the phototype and to the part of the body affected, and with the characteristic that we are going to treat the 3 steps of hyperpigmentation: pre-synthesis, synthesis, and post-synthesis of melanin. So when we're going to treat pre-synthesis, we're going to use active ingredients that are going to control the stimuli that influence on the melanocytes. When we want to control synthesis, we're going to act directly, inhibiting tyrosinase enzyme. And when we're acting in the post-synthesis, we're going to use active ingredients that can induce the changes to the synthesized pigment. So there are especially keratolytic and treatments to lighten that pigmentation in our skin. So it's a very easy to use treatment because it's very graphic. We have some lines on the packages. The products that we're going to use in our clinic, the professional use products, they have a red line on the package, and the 00 are the products that are going to prepare our skin. The 01 are the products that we're going to use as treatment in our clinic as professional use. And then the gray line, as you can see, are the products that the patient is going to use at home to continue with the treatment, because it's as important, the treatment that we're going to do at the clinic, as the treatment that the patient is going to continue doing, because the treatment is the whole treatment, clinic treatment and home treatment. So now we're going to start and talk about melasma. Melasma, as you know, is the most common acquired hyperpigmentation on the face, and we have three patterns. We have the central facial pattern that affects the forehead, nose, chin, and cheeks, the malar pattern that affects the nose and cheeks, and then the jaw pattern. And depending on the involvement, where the melanin is, as we saw before, we can differentiate between superficial melasma or deep melasma. So this is the same we were talking about before, about the epidermal or dermal type. And these are the professional products we're going to use to treat melasma. Now, we're going to start with the ID. ID are the initials for intradermal. So this is one of the two treatments that we have to treat melasma. So this treatment is a transdermal delivery solution that we can use it or with microneedling or with some devices that do transdermal treatments, or you can inject it. This depends, the technique depends on the regulations of your country. For example, here in Spain, we use a micropen or microneedling to use this treatment, but I know in some other countries, and I think in your country too, you can inject the product. So what are the ingredients? Well, as you can see, all the three colors of the pre-synthesis, synthesis, and post-synthesis. As you can see, the active ingredients act all in all the phases of the synthesis of melanin. We have tranexamic acid, glutathione, as a potent anti-inflammatory too, ascorbic acid, niacinamide, or magnesium gluconate. So what is the application protocol? First of all, we clean the skin of the patient. I think you don't have this gentle foam, but you can use whatever cleanser you have in your country. Then we disinfect the skin and we apply all the content of the ampoule to the skin of the patient. That you can do it with a microneedling or injecting. And finally, you clean the skin. So I'm going to show you a video. We'll go fast so we can see more slides. This is the product. It's 2 milliliters, and it's important to use all the quantity, all the 2 milliliters. What we recommend is to apply it all over the face, because apart from treating melasma, of course, that's our objective. But these products, because of its active ingredients, it gives that antioxidant and then anti-inflammatory properties to the skin. So it's going to brighten our skin. You can see a more luminous skin. You can see a glowing skin. So it's not only the pigmentation that we're going to treat. We are going to treat, of course, the quality of our skin too. Some doctors ask me if you can combine it with peeling that we'll see before. Of course, you can combine it. You can use it between the sessions of the peelings. And an advantage of this treatment, the Meline ID, is that it doesn't irritate the skin, whereas the peelings, you have some days that the skin is irritated, is inflamed. This technique doesn't inflame the skin. So especially for ethnic phototypes, or maybe patients that you know that they're not going to use photoprotection and you want to treat the melasma, maybe this is the ideal technique to treat melasma if the patient is not going to do a correct photoprotection after. Or maybe the patient tells you that they don't want to get irritated and they want a treatment to treat their melasma, their hyperpigmentation, and to reduce the hyperpigmentation, but they want to get irritated. So this would be the ideal treatment. So as you can see in the video here, we inject the product, all the 2 milliliters all over the face. Okay, so we'll go through the presentation. Oops, sorry. Oh, no, sorry. So this is the results. Oh, I didn't say. We recommend 3 sessions of Meline ID. The interval could be 2 weeks, 15 days. So this is the results after the 3 sessions. And as you can see, the skin has improved a lot. Not only the lentigos and the melasma that the patient has, but also the quality of the skin. You can see it's brighter, it's more uniform, more luminous. So the second option that we have to treat melasma is ethnic skin. We have 2 types to treat melasma. We have 2 types of peelings. We're going to focus on the ethnic skin because it's your type, your phototype. In aesthetic has the Caucasian skin, which is indicated for phototypes from 1 to 3, and we also have ethnic skin, which is indicated for phototypes 4 to 6. So this is the ones you're going to use. We have a professional key chemical peel that we're going to use in clinic. And then the second step, and as important as the first step, I want to focus on this and emphasize this concept. As important as the professional use is the home use, because we're not going to get the same results if we only use the professional use and the patient doesn't continue with the treatment at home. So in this case, before the peeling, we have a product that is called Meline Prep that is going to prepare our skin. And what is this product going to do? This product is going to repolarize our skin. It's going to decrease our pH. And this is for to better tolerate the peeling, so it's not going to be so aggressive, and all the active ingredients could penetrate better without being aggressive. So these are the active ingredients that we have in Meline Prep, acting in the 3 phases that we said before. We have lactobionic acid, lactic acid, ferulic acid, thiotic acid, and nonapeptide. Nonapeptide is a really important ingredient. This peptide is going to block the receptor of MSH, of melanotropin. So this is a really important active ingredient that it is present in other products in the Meline line, and is going to inactivate this tyrosinase. So after the prep, we have the peeling, and here, as you can see, we have high concentration of different acids. We have mandelic acid, ascorbic acid, tranexamic acid, phytic acid, and retinol. So it is a very complete formulation with high concentration of active ingredients that are going to be really effective on treating our hyperpigmentation. So this would be the application protocol. First of all, we clean the skin of our patient, and it's also we also recommend to degrease the skin. That is different to the prep. It's a different concept. When we degrease the skin, we're going to eliminate the sebum, so the ingredients could penetrate better. And then we apply the melanin prep that I was telling you that is important to repolarize the pH of our skin. And we are going to leave it around for 3 minutes. The time it doesn't have to be 3 minutes radical, especially in ethnic skin. Because if you notice that the patient is having the sensation of burning, there's a discomfort on the skin, you have to retire it before the 3 minutes. So this is approximately, but if you see that your patient is getting irritated, you have to clean it before those 3 minutes. Then we apply the ethnic skin, the peeling, and we leave it around 30 minutes. But this depends also, I say the same as with the prep, this also depends on the tolerance of the patient. If the patient notes any kind of discomfort, you have to clean it, okay? So then after the 30 minutes approx, then we wash with the help of Miline or whatever foam you have, and then we apply Moist, which is a moisturizing cream and recovering cream that we use here in Europe. I think you don't have it, but I'm sure you have something similar. So this would be the protocol. We recommend 3 sessions every 30 days. And the time depends on the tolerance of the patient. So in my recommendation, especially for ethnic skin, is always to be cautious, because as I told you before with the presentation, if we do any kind of irritation, it's going to trigger again all the pigmentation. So it's really important to be very mild, to be cautious with our patients and not to irritate, because we're not going to improve the skin of our patient. It's going to be all the contrary. It's going to be worse. It's going to worsen our patient. So this is the protocol of the treatment. Well, I go quick through this. We clean the face, and then we apply. You can apply it. I don't know how you usually apply the peelings. You can apply it with cotton buds, like here in this video, or with a fan brush, or wherever you feel more comfortable to apply the peeling. So all the layers of the peeling depends on the tolerance, of course. If you apply one layer and the patient tolerates, you can maybe apply another layer. But my recommendation, especially in ethnic skin, is only to apply one layer, because if we do more layers, we're probably going to irritate our patient's skin. So that the first product that we were applying was a prep product, okay? And then, as you can see, ethnic skin, the peeling is like a creamy peeling, a yellow creamy peeling that you can apply it. Here in this case, I think the brush is too small. I'm sure you use a bigger brush to apply it. So we apply the product all over the face, as you can see here. We leave it for 30 minutes, as we said before, and then we clean it. Okay, and then after the peeling, we put some restoring cream, recovery cream. And of course, very important, after the cream, we want to use the sun protection. We have a BB cream. We have 2 BB creams, the light and the dark BB cream. I'm sure you prefer the dark one, and that would be all the treatment. Okay, now the second step of the treatment, that is as important as the first step, is the home use products. We have 2 products. We have ethnic skin day and ethnic skin diet. Maybe the patient is going to ask you, and is it compulsory, obligatory to use both products? And we have to say yes, because the active ingredients are different. When we talk about the ethnic skin day, it's a product that what we're going to achieve with this product is to eliminate that pigmented skin with all this acid, with phytic acid, pyruvic acid, glutathione, tranexamic acid, salicylic acid. All, as you can see, the percentage of the active ingredients are lower. So it's a kind, it's a mild home use product, but it's very important because it's going to help us to eliminate the pigment that is already in our skin. And then the Skin Night product, as you can see, we have some other ingredients. They're different, so they're complement to the day product. And here, what we want is to prevent pigmentation. We want to avoid all those triggers that produce pigmentation. So they are complementary products, and we have to recommend our patients that they have to use both products. As you can see here, the ingredients, you can see we have low concentration of acids and retinol. So it's usually a well-tolerated product that the patient always, normally he or she is going to tolerate with no problem. So now I would like to show you quickly some results of some studies we performed here in Spain with Dr. Garcia Guevara. This is a study we did 2 years ago with both treatment, ethnic and Caucasian. And 60% were ethnic and 33% were Caucasian patients, a total of 103 patients. Those are the treatments that the patients used before. They're the usual treatments: pharmacy creams, hydroquinone peelings, formulas, laser. And what these are the results. You have to know, I'm sure you do, that melasma, or in general all the hyperpigmentations, are chronic diseases because patients have to be nearly all life treating their melasma, because although we improve and although we are going, of course, we're going to improve our patient's skin, if we are not constant and if we don't keep the maintenance treatment, the pigmentation is going to come back. So it's really important to transmit this idea, this concept to our patients, because if not, they're going to be disappointed about the results. So the results in this study, what we saw is that nearly the 80% had clearance of pigmentations. 50% had 60 to 80 clearance, and the 6% had 80 to 100 clearance. I want to focus this because, as you can see, it's not really 100% clearance in the patients, but it's a very good clearance. Most of the patients got a very good clearance with the treatment, and of course, that this has to be maintained all over the years. But also, as I was telling you, because of the active ingredients, we're not only going to treat hyperpigmentation, we also are going to treat quality of skin. We're going to achieve the increased luminosity, a greater elasticity, a lifting effect, and all the patients, they had positive effects, and they felt that it was a really good treatment for their skin. So these are the results, as you can see, before and after 90 days, before the 3 sessions. Of course, it's not complete. It's not a complete clearance, but as you can see in the previous image, the results are really good with our patients. See here the patient, the luminosity and the glowing of the skin too. So more patients. As you can see, very good results in this patient. Here, there's a dermal pigmentation that is the most difficult pigmentation to treat. As you can see, very good results with the treatment. So another dermal pigmentation with great results. So this is another study that was performed in 2017 that it measured with several variables, the MASI score, Ameesha Dermacat. Well, I'll go quick with this. These were the melasma severity. Most of them were moderate. And what I want to focus is the results after 4 months. If we compare it to placebo, you can see the difference and the difference between before treatment and after 4 months treatments with Meline ethnic skin. You can see MASI decreased from 18 to 8, Mexameter, which measures the quantity of pigmentation and also vascularization, from 93 to 38. And Dermatologist, it's an image, digital image analysis. It also improves a lot, from 65 to 23. So these are the results. As you can see, the quality of the skin has improved a lot. Here, more patients. And here, we're going to talk about dark circles after, but here you can see that with ethnic skin, it also improves. And this is another study that Dr. Zambrano performed in Dominican Republic. And these are the results of his study, that also the melanin was decreased, the MMACid decreased, and the eta value, this is the opposite. The eta value that is measured with chromometry is the higher eta value is the less pigmentation. So that's why it improved. So these are the results of our patients after 90 days and after 120 days. You can see this was a very severe melasma and how the patient improved. This one was also really severe with dermal and mixed hyperpigmentation, that she was quite better. She wasn't completely clear, but she was quite better. And more examples. And now the last topic that we're going to talk about is dark circles. So there are several names to name this entity, dark circles, and it's a common condition that it really is very difficult to treat sometimes, and really affects the quality of life of our patients. So it's really important to have an option to treat these dark circles. So Meline offers us this opportunity. But in the pathogenesis of dark circles, it's not only the pigmentation, because sometimes in the pigmentation of this area, there are some post-inflammatory hyperpigmentation, not only to inflammation, but always and sometimes for excessive vascularization. That happens especially when we have surgery, when we have rhinoplastic surgery or blepharoplasty, that we have excessive vascularization, and that is going to influence the pigmentation of our periorbital area. So this would be the classification that I'm going to go fast with this. We have the pigmented, the vascular, the structural, and the mixed forms, of course, combining all the previous forms. So this is to differentiate all the types, vascular type and pigmented type. As you can see here with the UV mode, we can differentiate those types. And if we look our patients with multispectral imaging, we can see that patients that have dark circles, which are these, are more pigmented, and they have more melanin and more hemoglobin, more hemocysteine. That's why vascularization in this area is so important. So we also have seen that that when we have dark circles, the skin is thinner when the patient have the pigmentation of the periorbital area. And if we do video capillaroscopy, when we have dark circles, the capillaries are wider, as you can see here. So vascularization is an important topic when we are treating periorbital area. So these are the products that we have to treat dark circles. We have the products that we're going to use in clinic, the professional use, that is two-step, the pigmented kit, and then the home use that is going to be an easy roll-on for patient that is quite easy to apply. So these are the ingredients of step 1 and step 2. Step 1 has chloroacetic acid and lactic acid. And the second step, we have phytic acid, vitamin C, and vitamin A. And after the treatment in the clinic, then the patient has to go on with the home use. And in this case, the active ingredients of the home use product, also we have, of course, some acids to decrease the pigmentation, but also, as you can see here, all these active ingredients are going to work over they're going to act as venotonic ingredients and antioxidant, and they're going to stimulate microcirculation. So that's why it's so a special product, because it's not only going to work in the melanin pigmentation, it's also going to work in the hemoglobin pigmentation. So this would be the protocol. First of all, we're going to clean the area, and we're going to do the first step. The first step is the first product that we saw before, step 1, and we're going to use from 0.3 to 0.5 milliliters. We're going to apply it with cotton swabs. And here is not, the time is not so important, is the layers that we're going to apply. So here I would recommend, my recommendation for ethnic skin is to perform only one pass. And maybe some patients could tolerate a second step, but in my opinion, I think for ethnic skin, it's better only to perform only one pass to avoid that inflammation that is going to trigger again more pigmentation. The recommended protocol is one session every 15 days for 4 sessions. And in this case, what we recommend is to maybe the interval to be wider, longer. Instead of 15 days, maybe 45 days to prevent that hyperpigmentation, to prevent that inflammation. And in the case of the home care, when we recommend the patient is to start slowly, to start only twice per week, and then if it's well tolerated, she can or he can increase the application. Okay, so in the professional use would be the step 1, then the step 2, that the same, only one or 2 layers, and then we could leave it for 15 minutes, but this is approximate, as I told you before with melasma. The time is not exact. No, it depends on the tolerance of the patient. So approximately 15 minutes. But if the patient notes any kind of itchiness, any kind of discomfort, of course we're going to wash it before. Then we wash it and we apply some restoring cream. So this is the protocol of dark circles. We're going to wash before. Of course, you can combine dark circles with any other professional peeling. You can do maybe the ethnic peeling. Yeah? We do some degreasing here. In the periorbital area, it's not compulsory to use the degreasing solution. For example, I don't use it because there are very few sebum glands here. So sometimes you don't need, especially if the skin is very dry or the patient has a very sensitive skin, maybe you can avoid the degreasing solution. Then you apply the first step. You get 0.3 or 0.5 milliliters, and you apply it in the upper eyelid and in the lower eyelid. This is the first step, and then we have the second step here. You see the second step is like a bit yellow. And then after applying it, then we put the restore cream. And of course, we put some photo protection. Okay, so as you can see, it's a very, very easy protocol. And these are the results of some of our patients. As you can see, it has improved a lot. More results. It's not going to be cleared completely, but you have to tell the patient that then they have to continue at home, and of course the this is Dr. Guevara, our doctor. As you can see, he improved a lot his dark circles, as you can see here, and more results. So that's all I wanted to tell you. So thank you for your attention. And now I'm open to any kind of questions or whatever you want to ask.
Thank you, Dr. Anna, for such enlightening and exhaustive sessions. We are open for the audience questions also, and I have a set of questions which we can discuss. And just hold on. Yeah. So we know now that we have already introduced Dr. Anna and Dr. Ameesha Mahajan. There is Dr. Pallavi. I think Dr. Bharti is not there. We have said I'll first take the audience questions, Dr. Anna. There are few set of questions which I have promised them to take it. Just hold on.
So how common is melasma in your practice? Well, it's quite common. It depends, I suppose, on the countries. Here in Spain, we are, well, phototype 2, 3, 4, and it's more common in high phototypes. And especially it's something that, as I told you before, we have to deal with it nearly all life, because patients maybe can improve and they go to a doctor and do some peelings and do some treatments. But I think the most difficult is the maintenance phase, the maintenance treatment. So sometimes patients get tired and they leave the treatment, and of course pigmentation is back and we have to treat it again. So I think it's really important to emphasize.
Relapse and recurrence is the challenge always in the Indian setup also. I'll take Dr. Pallavi's take on this. Now, how common is melasma in your practice? This is what we all know, but the first question is so that I can understand my panelists and accordingly. So that Dr. Anna should also know how we treat our melasma. We'll take our Indian take also on that.
Yes, sir. Melasma is definitely very common in my practice. Daily, every fifth patient must be a melasma patient.
Okay. And I think same is with Dr. Ameesha also.
Yes, I would say nearly 40 to 50% of my patients would be melasma.
Rather, we can reframe the sentence that in around 50% of or more than 50% of pigmentation cases are melasma in our Indian set of practice. Yes. So, just hold on. I'll come directly onto the meline. We all are using meline. That's why we are here. Dr. Pallavi, which are the meline products are you using in your practice? Then I'll come on to the melasma burning questions, which we all the audience want to ask, and there are a few set of questions from the audience itself. So my first question that what are the meline products are you using in your practice?
Yes, sir. I'm using meline peel for the face and eyelid area.
Peel, are you using home care also?
Yes, complete set.
And how do you select the patient for which patient profile benefit the most?
Sir, instead of melasma, I prefer them in other patients for the face, particularly patient who have photo damage and deep kind of pigmentation. And melasma patients, yes, definitely. But for all of my melasma patients, we don't promise them that this treatment is just for melasma. We tell them that it is for overall rejuvenation of the face, and melasma will improve along with that. And that is how we convert patients for this treatment for the melasma patients too.
You do treatment per se means we use one also and then the home care also. Like yes. I'm not using one, I am only using the day and night, the night ethnic cream and the day. The home care more often along with the other agents.
Achha, okay.
I'm combining it with the other peels also.
Achha, okay.
And this is how I'm doing, and I'll take Dr. Ameesha's opinion on this. Dr. Ameesha.
So I'm predominantly doing it for melasma cases.
Yeah.
I do peel. More commonly, I'm using the Meline 2. I've not used the day. I'm very happy with the Meline night cream, basically.
Yeah.
That I use in a large number of melasma cases. And sometimes I give it even without a procedure. So even without using meline peel or any other peel, I just give it as a um, treatment along with oral medication sometimes.
So you are using it as a monotherapy or using it in the combination therapy when you use mentioning this meline night cream? Are you using it as a monotherapy or are you using with other topical agents as well as the oral agents?
So normally, so I use it twice to thrice a week because I do see inflammation in my patients, even with Meline 2 a lot of times. So on the other days, I give them something which is milder, something which will not give redness at all. Meline 2, the night cream that I use, it does give redness and inflammation sometimes. So I use it twice to thrice a week to start with, and then make it every night for patients who are able to tolerate it well. I usually always add some form of oral medication, whether it is oral tranexamic acid or even some cases who are not going to have oral tranexamic acid, but some oral antioxidants are always a part of my prescription.
Dr. Pallavi, do you combine with the topical hydroquinone or topical azelaic or kojic acid creams? I mean to say any other topical creams along with meline?
Absolutely, sir, because I don't think that melasma can be treated just with one medicine. So we take a complete systemic approach also. Like we make it sure that there is no triggers to the melasma, even systemically, any kind of stressors. If the patient is not sleeping properly, we improve that. If there is any inflammatory process going on in the body, we make it sure that that goes away completely. Then sunscreen plays a major role, and then oral antioxidants, and along with that, the treatment. So I don't feel that it is just a role of one medicine.
You don't rely only on the monotherapy of meline.
Not,
This is what you
no,
mean to
not
say.
at all. Yes, sir.
Um, we all believe in this. I'll come to Dr. Aina then. We'll discuss about the protocols you follow in your practice regarding meline, especially the home care. I wish to ask you. I'll just mention how we do it. I generally ask the patient to first moisturize and then apply the meline night ethnic cream, and I use it regularly for a month. Most of the patient don't complain any irritation or dryness, but initially I do counsel them that first 4 5 days there can be mild exfoliation, and then gradually I notice if there is any exfoliation or the visible exfoliation is there, I ask them to apply alternate day along with the other agent. Then I do combined with the topical hydroquinone also on the. It's like using it as a cyclical therapy. 3 days a week, meline night cream and 3 days a week hydroquinone. So what's your protocol about this meline night and day cream, Dr. Anna?
Yes, here what we recommend to the patients is after the professional peeling, we advise them to wait at least 4 or 5 days, as you do, and then start with night cream and day cream, both of them, twice a week. If it's well tolerated, in 1 or 2 weeks, three times a week, and then 4 times, so they can increase the application. Of course, you can combine it with oral tranexamic. Of course, I also use oral antioxidants. Hydroquinone, I use the Kligman formula too. So, I mean, I think it's easier for us to treat low phototypes than higher phototypes. Yes.
And I'll come on to the protocol again. You said that first 15 days you use it regularly and then alternate day, then twice weekly. This is what we have. I'm talking only about the home care cream, the meline ethnic night cream. So generally we are not using the meline one in our practice. We use generally the meline night and the day creams in our practice, along with the other agents, maybe the oral tranexamic acid and maybe other peels. This is what how we are practicing. So we wish to know more about the meline day and the night creams. Suppose if we are not doing meline one, only using the home care products, what should be the ideal protocol for that?
For you mean only to use the home
Only to
home?
use. Yes.
Yes, if patients maybe sometimes patients don't want to do the peeling, so they can use home. But as I was saying, we don't start every day. We start 2 or 3 days a week,
Okay.
and then when we have good toleration, and then they can apply it 3, 4, or 5 days a week. What we want to avoid always is inflammation.
Okay. And do you combine with the topical hydroquinone or any other topical agent, or you use it as monotherapy, as home care creams? If you are not, if you
Well,
are not doing the in clinic treatment, that is the part one.
of course, if you're not doing the in-clinic treatment, yes, always, because you need something else to treat melasma.
Okay. So now we have the varied protocols from the panelists. Dr. Ameesha is using it initially at alternate day and then gradually twice weekly. Uh, Dr. Pallavi is using it regularly, I think, and then switching over to alternate day. Like I am also doing the same. My first month, I generally say use it regularly once at bedtime, and then after a month, if you when you start noticing the desired results, you can start applying it alternate day. And sometimes I do combine with hydroquinone also, as we discussed about the as a cyclical therapy. 3 days a week meline night cream and 3 days a week hydroquinone. This is how we do. And along with the yes, sunscreen and the moisturizer is a must. Whenever I'm giving any meline night cream or day cream, I generally say the first coat you should moisturize first and then apply it. So this is what our protocol is kind we have developed it. So we'll follow the what you have said, Dr. Anna. We'll go on to that, the more clinically proven.
Yes.
Now coming on to the meline versus traditional therapies. I'll take Dr. Pallavi's opinion on this. Dr. Pallavi, are you there?
Yes, sir.
Yeah, but how do you compare this hydroquinone-based regime with the meline only? Because meline also have so many superstars. If you see, in higher percentage, it has got tranexamic acid, then it has got arbutin, it has got you name it. It's there mandelic acid in 10%.
Mine is also there. Yes.
So
Not,
salicylic is there, phytic is there.
yes. Sir, I have not used it as a, like, I have not done any kind of comparison between two different cases of traditional therapy
It's
versus.
just your experience. It's not. I'm not talking about any essay research. This. I'm just asking you clinical experience about this.
So in the clinical experience, sir, what I have seen is the superficial pigment, when it is epidermal, it goes very, very well with our hydroquinone-based regimens and mixed melasma also. But in the resistant cases, mainly meline gives good results.
Okay. I'll come to the question again to Dr. Ameesha. Now, how do you rate this meline home care creams, like especially the day and night, for the maintenance therapy of melasma? Suppose if once we attain the good result from triple combination or hydroquinone or in combination with the peel or the lasers, can we use it as a maintenance therapy for a longer period of time, maybe thrice weekly or twice weekly regime?
Yes, sir. I do have a lot of patients who've been on this as a maintenance regime for quite some time now, for a few years also. I don't use triple combination in my practice at all. I do use hydroquinone, but I also use hydroquinone sparingly because of the risk of self-medications that we have in the patients. So most of my cases on Meline are as a standalone. The other use that I'm going to use, the other product that I use in between for cyclical therapy, that's usually a milder agent, not something like a hydroquinone that I use.
Okay, so you're using it as a regular, as a first line of management also, you're using it as a maintenance therapy also. This is
Yes.
what you mean to say. Dr. Anna, I'll take your opinion on this. Meline home care creams as a maintenance therapy in melasma. How do you rate it?
Yes, I think it's crucial to maintain them. And what we recommend is to start just 2 or 3 days, but if the patient tolerates more days, to maintain it for 4 or 5 days every week for months, even years. I mean, they can stay with the treatment for a long time.
Okay. So I think the with all the panelists and me as a moderator, we have consensus for one thing that yes, this meline day and night cream can be used as a maintenance therapy for a longer period of time, safely and efficaciously for a longer period. I have used meline now since a long time. The first meline experience for me, Dr. Anna, was in 2010. 11. Then I was the one of the first one to use it. Then I used the first also, and since then I'm using it with various distributors. Of late, I'm very regular since last 1.5 to 2 years. So now we are using in various other facial melanosis also, and then we are getting see to know more about it, how to combine it, when to combine it, with agents to combine. So in my this generally in the resistant melasma, which are not responding to the other treatments, I do combine it with hydroquinone and meline regularly. Yes, it makes it a little aggressive, but if you counsel the patient well, initially for a month, we get desirable results, and then we can do the maintenance with the same agent in a cyclical way, what we have discussed. So this is what how we are using in our, and we are not using the part one. Maybe with after this event, I'll try it again. So coming to this, just sharing one of the result. This is after 8 weeks of application of meline ethnic night cream. Nothing else was working, and nothing else has been used also. Just a night cream, a sunscreen, and a moisturizer, which is regular with my meline. The first coat is always the moisturizer. Now, do you combine meline range with other demelaning agents? If yes, which molecule is your choice, Dr. Pallavi?
Sir, double combination hydroquinone with tretinoin.
Okay. And doesn't it the increases the irritation potential?
No, sir. I give it just for short application for 15 to 20 minutes, and I ask them to wash it off.
Okay.
Alternate day meline.
15 to 20 minutes of that hydroquinone and tretinoin combination, you mean to say this. And after that, apply meline.
No, on the next day applying meline.
Okay, you're not using it the same day. I'm asking same day, are you combining it with any other agents?
No, sir.
Topically. Dr. Ameesha?
Not the same day, sir.
Okay. Dr. Anna, can we use any other agent along with meline? Suppose if there is a resistant melasma, can we use it with hydroquinone like I am doing, or?
Yes, I the same, not the same day, some other day.
Okay, as a cyclical therapy.
Yes.
Maybe can we, if the patient is not willing for any procedure and he is well counseled for the downtime, maybe sometimes it's there, sometimes, and downtime is very, say there is a mild exfoliation for 2-3 days, then it gets back to normal. So generally what I do, I generally plan it for, depending on how the patient is taking it in terms of how, if they're doing it regularly and there is no visible adverse effects like exfoliation or redness, erythema, then I generally counsel my patient to continue it for a month. And then gradually I come to the cyclical therapy. This is how I'm using in my practice. This is I'm sharing. And my molecule of choice is the azelaic and retinol-based the liposomal serums with the meline night. And sometimes I do use it with hydroquinone 2% also. So male melasma, this is recently, I find it is a very challenging cases because the compliance is always an issue with the men. And then the irritation potential of men is higher than the women. This is what, in terms of you asked, the skin irritation. And they don't see whatever counseling you do, it's not easy to make a male compliant to the topical therapies. So how commonly you see in your practice, Dr. Anna, the male melasma? And what racial and ethnic considerations do you make before selecting an agent for the melasma, for the male melasma specifically?
Yes, it's not that common. Well, I mean, it's not that common, or they don't ask for treatment that as common as women. But I'm sure the hormonal issues is more important, much more important in women than in men. On the contrary, men usually don't use sun protection, so they have some other triggers that worsen the melasma in men. So it's not that frequent, but I think it's more difficult to treat because they're not so constant with the UV protection and the treatments.
I think due to emergence of a lot of factors, like one of them is social media, and the men are also getting into the picture. I'm seeing of late that men are becoming more compliant to the therapies. I'll take Dr. Pallavi's opinion on this.
Yes, sir.
How common is male and melasma in your practice?
It's the past few years, I have been seeing more
Yes.
patients of melasma, and particularly melasma, which is combined with PDLs on the male
Yes.
face, and particularly with people who are more exposed to sunlight and people who have habit of rubbing and scrubbing their skin, probably
So
because of some kind of inflammation, the melasma gets triggered.
you
And
consider more occupational factors for that, or
uh,
the
I'll say more habit related things rather than occupation. But then I usually see it in people who use more fragrances, who are more used to doing any kind of rubbing, scrubbing activity, and people who have some family history of melasma. These are the things that I have seen in my practice.
So what is the most common companion morphology do you see, Dr. Ameesha, along with melasma in men? Do you see often, like one she said that PDL, some metabolic disorders also are being associated of late with male melasma specifically.
Yes,
So
sir, and
what
also photo aging. The
photo
people,
agent?
so we notice that people who are men who are coming to us with melasma, you'll notice more photo aging in them.
And how do you counsel men for any kind of peel or laser treatment for melasma? And what's your go-to agent when you are treating a melasma in men? What's your ideal prescription for that?
So what I have seen is, like you said, men are not that concerned about pigmentation, but the ones who actually reach the clinic, I would say
Yeah.
they're very compliant. So
And sometimes I notice that it's all depends on social setup also.
yes.
Uh,
So mostly if they have melasma, either they're not coming, but the ones who come are usually very good patients, maybe even
mm.
better than women. So and one challenge I
I,
face,
I generally say that for every man seeking a melasma management, there is always a woman behind that. Somebody forcing from the family,
sir, or social media,
maybe
like you said.
social media and rest of other factors also.
Yes.
So,
One thing I do
what's
in men is I rarely use peels in men because of the occupation, more sun exposure, even they cannot. Most of the men do have some form of a social interaction more than the women patients. So I don't do anything which is very exfoliating when it comes to men, unless they are insistent upon having a peeling session done and they're open to the idea of exfoliation and maybe taking off from work. So that is when. Otherwise, my ideal prescription is oral medication. I've also seen men respond very well to oral tranexamic acid somehow, even more than women, if I may say. And then they even respond well to topical agents. I think men who are compliant with their treatment, the response is better.
Acha. To me, the thumb rule is the less agents in melasma, as less creams you have to prescribe. The prescription in men should be very small,
Mhm.
maybe a two, three agents. So I generally, and they are one of the best takers for the meal take, because the cost is always an issue in India. So I think for the men, I do prefer this meal night ethnic cream and night two serums in the morning, evening, maybe a moisturizing sunscreen. This is what my ideal prescription for a man of late is. So, and then the counseling is very, very important regarding the sun protection because they are not very good at applying regular sunscreens. So to them, just counsel them that how to protect from the sun.
Agreed, sir.
So I won't take this question now. I'll come on to this melasma. Your preferred procedure, just one slide for the procedures because we all are aesthetic practitioners. And I personally think that for melasma, the procedures are not always the first line of management. But yes, the combination makes a difference. I'll take Dr. Anna's opinion on this.
Yes, for me, the ideal is to combine treatments. Pills, PRP, I have very good results with combining PRP with pills. And of course, I like to use oral treatment, I mean, or oral tranexamic acid and oral antioxidants. So laser, for example, I don't like lasers for melasma. Yes, for lentigos or other kind of pigmentations, but I think it's not the ideal treatment for melasma.
Okay, Dr. Amisha.
So, I like laser toning for melasma if I have to choose a procedure. But for patients who will be, I like laser toning because there's no downtime to the procedure. It's easy for the patients to get it done. When we are doing peels and PRP, there's definitely some downtime, whether it's in the form of bruising or exfoliation when it comes to peels.
I'll reframe the question. Does PRP work in melasma?
Sir, it does, but I've
And
also seen rebound.
what exactly does it do in melasma? This is why we do PRP in melasma? This is always a question which I ask. Why should we do?
Sir, it reduces the inflammation because of the growth factors. I've seen good results, but in the same patients who've gotten good results, I've seen a rebound come back. So it's not my treatment of choice, but sometimes patients will say if they've tried PRP and it works for them. So
Mhm.
that is when I offer PRP for melasma.
Okay. So I'm not a big fan of PRP in any kind of pigmentation. But of late, I'm seeing that the skin boosters I am using in melasma. I'm using it as an intralesional, 0.5 ml each lesion. This is what every side. And I'm seeing that it's working now. You've seen my presentations at the conference also. But the right selection of the booster is uh, is the main, I'll say, the golden rule behind selecting any booster for the melasma. Now, coming on to the tranexamic acid injections, they are intralesional DA. Any of us are doing that? Dr. Pallavi,
No,
have
sir.
you ever used it?
I have used it in past, sir, but there was no consistent result with it, so I have stopped using it now.
Okay. So I think the peels are the first line of procedures along with the medical management in melasma. But rest of the procedures are like hit and trial. I do agree with Dr. Ameesha that the all the skin rejuvenation lasers, specifically the Q-switch laser and the carbon peel, what we do, it definitely works in melasma. But the parameters need to be seen. So this is after 3 months of nothing. I have never used the one of late. So this is after day and night cream combination of meline, nothing else. And this is after 90 days, the result of only meline. And this is a meline night peels. This is the mask retinol peels, nothing else. Every 15 days and along with this meline night. So coming back to this, the how I use just to say it, because this I just added this slide because there's a question by this one of the audience asked this question is that what exactly the I'll take it, I'll just pass it on to the panelists also. The question was that what agents do you use to reduce the vascularity of melasma? What's the treatment for the vascular component of the melasma? Anybody? Dr. Anna, I'll take your.
Well, sometimes when there's an important vascular component, I is maybe the only time that I also use laser for that. But for treating the vascular component, I mean the meline, as I was saying, it also has that anti-inflammatory and antioxidant effect. So here in Spain we don't inject. We do transepidermal with microneedling. So I don't use anything specific for the vascular component. I don't inject anything.
Okay, Dr. Pallavi.
Sir, I give locally azelaic acid and vitamin C and orally antioxidants, and I use Genesis mode of India for these kind of patients.
Okay. Dr. Ameesha.
The oral tranexamic acid.
Yes. The first line of management is oral tranexamic acid and the topical tranexamic acid. Then you can use azelaic acid. We use the blue light lasers, the diode 450, along with IPL you can use, and the pulse dye laser. These are the major, these are the only things it's considered to be. And then PRP is one of the things it's said to be there that works on the vascularity of the pain. They offlate the hyaluronic acid based along with other the mixed breed of skin boosters. So what I do, this is the slide for because this works on the pigmentation also and reduces the plasminogen, so that reduces the vascularity also. The injection tranexamic acid 100 mg per ml injection, and I combine it with injection ascorbic acid at 0.5 ml of each in 1:1 concentration, and it's injected into superficial dermis. And this is with the result after interval. So this is the final slide of the questions, the rapid fire round, just yes, no, or maybe a very short answer. The most effective topical ingredient for melasma, Dr. Pallavi.
The triple combination.
Dr. Ameesha.
A lot of ingredients work. I think it really depends from patient to
Short.
patient.
Rapid fire. Out of lot, you have to choose one. Which you rely the most?
If I rely the most on Meline 2 night cream. If I'm stuck, that's what I use.
Which one?
Meline 2 night cream.
Fine. Okay. And night cream. And Dr. Anna.
Well, I like retinol acid, of course, but I
Really?
combine. I always combine active ingredients. I can't choose only one. So if I had to choose one, I agree with Dr. Ameesha. I would like
Combination cream. Nobody has said hydroquinone actually. Triple combination, one of it's a good it's a very I'd say the first line of management for melasma. We all agree to this. Generally, I use with any agent I'm using any prescription. Twice weekly or once weekly triple combination also I use for a longer period of time. And the most effective topical ingredient for melasma for me is the hydroquinone. If you see, with time we get to know how to use it and how long to use it and how so safely we can use it for a longer period of time. And the best maintenance therapy, again from Dr. Pallavi.
Sir, physical sunscreen in the morning and at night time, alpha-arbutin and retinol.
Okay, Dr. Ameesha.
Sir, I usually give combination creams, the ones which have a glycolic acid, kojic
Yeah.
acid, so like a gentler combination.
Okay. Combination cleanup like Kojak, butane, like everything is there and the higher percentage. Dr. Anna.
Yes, I like to combine also vitamin C in the mornings, and then at night retinol, glycolic acid, alpha hydroxy acids. I mean, combination that I think is the most effective combination.
Okay. During this maintenance therapy, do you like to give any spot treatment of triple combination, Dr. Pallavi? Maybe weekly, once weekly.
I usually ask them to use double or triple combination once a week or once in 10 days.
Achha. One mistake clinicians make when treating melasma.
Sir,
Dr. Anna. I'll start from Dr. Anna.
Sorry, if I use
One mistakes which clinicians generally make when treating melasma. What do you think according to you, the
yes,
biggest mistake in melasma is?
I think for me the most the most important mistake is you want to treat really intense the melasma. You want to be really effective, and you provoke irritation and inflammation. So that's going to trigger more irritation and more pigmentation. So I think that's the most important failure.
Dr. Ameesha.
Mistake.
Sir, I would agree to Dr. Anna. I think when you cause more inflammation in trying to help the patient, be it with
Agreeing is a better option. Dr. Pallavi.
Sir, avoiding all the if we avoid all the triggers, then that is the best way to treat. If we are not working on that, then it doesn't make a sense to do.
We are making a mistake. You mean to say that increasing the inflammation potential means if you're using laser as a first line of management, that can be one of the biggest mistakes. This is what we all agree to. Okay. Relapse in melasma is a rule. Is it true or false, Dr. Pallavi?
True, sir.
Dr. Ameesha?
no, sir.
Dr. Anna?
Yes, it's
Yeah,
true.
we all agree to this. So and you need good fortune to keep melasma in remission. True or false?
Yes, true.
So this is it's a loud and clear message to the audience what exactly we as a dermatologist think about melasma. Melasma treatment is just the multifactorial and multidimensional. The target one is to reduce UV damage. Target two is the suppress melanogenesis, where comes all the medical management and the oral treatment, oral tranexamic acid, and remove existing pigmentation, exfoliation, where comes the peel and there's the meline kits and the meline night and day creams, and destroy pigmentation if unable to remove. That comes the laser if you can. It's a double-edged sword. So this is what the melasma treatment goals are, and challenge in the treatment is main challenges are inability to destroy melanosomes and dermal melanin without triggering inflammation, which in turn stimulates melanogenesis and exacerbates melasma. Second challenge is to completely block UV rays and pathways that trigger melasma, and to make the, I'd say, the patient compliant to the sunscreen and the therapy. So the future goal should be melasma is a rising concern. Treating patient is a challenge to the dermatologist. Relapse is a rule in the treatment of melasma. The future scope of therapy options can be topical drugs controlling angiogenesis, vasculature, which will work more on the vascular component. Of late, there are a lot of companies working on this and coming with the newer agents. Topical therapy controlling the activity of keratinocytes. Topical therapy for disrupting the existing excessive melanin, and therapy for regulating the intrinsic factors, including hyperpigmentation. So now the take-home message, a short, sweet, one-line message to the audience. I'll start from Dr. Anna. Sweet and crisp
Yes.
regarding melasma management.
Yes. What I would like to transmit to the audience is that it's important to treat the patient, but also the patient has to maintain that treatment and do that treatment at home, and to concern the patients that it's an illness, or a disease that he's going to have for the whole life if he doesn't treat it. It's very important to do a maintenance and to avoid the triggers.
Okay, Dr. Pallavi.
Sir, I'll say melasma is a multifactorial thing, so we need to find out all the triggers, take care of them nicely. Always counsel patient for using sunscreen and go slow in the treatments.
Dr. Ameesha.
So I always tell the patients in the counseling that your melasma is not going to go. So once our patients understand that, and they understand that it's a lifelong maintenance that they're working at, I think they're happier even with a moderate result.
Okay. So we all agree that we need to be multitaskers when we are treating melasma. The counseling, the day one is very, very important when we are treating melasma. The first thing is to buy time, and the sustainability of the patient coming every now and then to you and relying on you is an art. How you can possess your patient for a longer period of time, counseling them, using sometimes active ingredient and sometimes just for the maintenance. And all comes with the counseling. This is what I generally say. The first line of management is the counseling in melasma. We need to be multitasker. Loopholes in the therapy we have already discussed. So thank you. And we'll discuss more about melasma in future. So that's why I picture Abhi Baki hai post. And lots to come in melasma. Newer treatments, many newer agents are in pipeline. With this, I'll thank you all. And if there are any audience question more, we can take that before we pass it on to Dr. Miloni. Do you have any more questions, Miloni?
I think more or less we've covered a lot of the questions that have come in with the discussion. One of the questions I think the audience asked was, how is Melan different from Cosmelan peel?
Okay. I think Dr. Anna can take that.
Yeah, Dr. Anna.
Well, I don't really know about that. I think that's another brand of the pigmentation.
Yeah, I'll take this question with the due permission of Dr. Anna and Aakaar, because this is a company platform. But even though the question is, because I'm using Cosmelan also since a long time, the total ingredients are absolutely different, and the percentage is also different. In Cosmelan, the azelaic acid is in higher concentration. That's the superstar in that. And then there are all the agents. But in this Meline, I think the azelaic acid is not there. And the overall protocol is different of Meline and the Cosmelan. So that's why these are different treatment. But principally, they have the more or less this their system is same. If they say it Cosmelan system, this can be the Meline system, because there is a home mask in that as a part 1 in Cosmelan. In this also there is a part 1 and part 2. So you can say the younger one is inspired by the elder one, but the concentration and the ingredients are different. but the idea of management, they work on both work on hyperbilinosis.
Sir, if I
This
may
is how we. Yeah, please.
uh, I have seen patients who are not able to tolerate Cosmelan are able to tolerate Meline. I have noticed that in some of the patients.
Yes, I do agree. And there is one persistent erythema in Cosmelan,
Yes.
which many of the clients like and many dislike, and then it becomes difficult to treat that erythema even after stopping Cosmelan. So this we are not here to discuss Cosmelan. It's more for
Yeah.
Meline in the it can be a universal product as a MelasmaManagement once you start understanding it more. And there was one question which we'll take it as a final question. I'll go on to the chat. It was very interesting question that how can the first one, Dr. Vijay Mane has asked, how can Indian people become fair in such a short time? I don't know what such a short time means, but I'll just take it. Half of the question is very interesting. How can Indian people become fair? Dr. Pallavi, can is this sentence correct? Grammatically, yes, it is. But do you think that clinically it's a right sentence to say that
No,
Indian
sir.
patient can become fair?
No, sir, definitely not. Whenever a patient comes to my clinic, I usually counsel them to go for the healthy tone rather than a fairer tone. So I don't feel that it is the right thing.
Okay, great. So we don't have any difference of opinion. I think yes, the skin brightness or the tone of skin can be improved to 1 to 2 shades depending on, and there are a lot of factors. It's not only the topical agents, it's not only the oral management, it depends on the lifestyle of the patient also. Stay home, be happy, keep on doing only skincare, don't work, definitely your skin tone will improve. So with this, I'll ask
I
Pallavi to conclude the
Yes. I actually
event.
have a question before we end the session for tonight. This is especially for our Indian panel and Dr. Neeraj, of course.
Yeah.
Do you guys think that there is a growing need for a Indian-specific melasma protocols in the market?
Yes, I absolutely
Dr. Neeraj,
agree
yeah,
to
you can
this.
go for it.
I absolutely agree to this. I'll take it as a question. And there are many companies which are working on this. Recently, one company, without naming, I'll say, has come up with the cyclical therapy in melasma, which
Right.
was a need. Which was, I think that's similarly. There are so many agents coming in India also. The like Mela Zero is there. Then there are various other. The Silimarine
Yeah.
is there. They are refurbishing the Silimarine in various percentage and combining with the things. So it's as per the Indian skin type, there is definitely a need to find the agents which suit the Indian skin more and can be used as a maintenance therapy and a corrective therapy also for a longer period of time. The safety and efficacy for Indian skin should be seen more. Because the protocol changes as per the Indian skin type. Suppose the me line, maybe Dr. Anna's protocol can be different to mine.
Yeah,
This is how we think about it. As per the skin type changes, the protocol also changes. So
absolutely.
I do agree with this, and I'll definitely it's all the best to the Aakaar for coming up with the newer agents for to treat melasma.
Yes, hopefully. Dr. Pallavi, if you'd like to answer.
Yes, definitely. The Indian skin differs from other type of the skin, and we tolerate higher agents very lesser. Even peeling agents we tolerate very lesser. We end up having some or other kind of pigmentation out of stronger peeling agents also. So we definitely need some milder ingredient. And even in the sunscreens, if we could come out with better sunscreens for melasma skin, that will also
Mm-hmm.
because sunscreen also is a major pillar in the pigmentation.
Yeah,
Hmm.
that's great. Yeah. Dr. Ameesha.
Yes, I think I agree to Sir and Dr. Pallavi that we need to have protocols for our Indian skin. And like rightly pointed out, it's all about having less inflammation in our skin because the moment, even if you use a good product and we are using it in our skin which doesn't tolerate it, your melasma is going to flare up. So I think
Hmm.
use all these newer agents more with caution and get good results.
That's great. Thank you so much. So if there are any more questions from the audience, we will just wait for a minute or two. Um, you can type it in the comments and we can just pop it up to the panel.
I think there should be, along with the newer therapies for melasma, there should be tutorial classes to the patient how to use sunscreen. This is
Yeah.
I'll let you know, because this is one of the major factors. I personally think that the sunscreen is more abused than used in most of the part in the world, because we don't understand that what is the right quantity of the sunscreen is. We don't understand that what should be the ideal frequency of applying sunscreen in an individual should be. See, Melanie, you know what is the ideal quantity of sunscreen? See, we are getting into all waterproof, with the
Yes.
makeup base, you name it, you have sunscreen with all the ingredients. But I generally ask patients, they are not aware exactly that how to use sunscreen, how much should be used, how long it should be used, how often it should be used.
Right.
2 ounce is 2 ounce, 2 ounce, how much it is?
Johnson.
It's
Yeah.
half a bowl, if I'm not wrong.
Correct.
So nobody applies, and then a lot of factors are there. So it's like sun protection is a very, very important aspect of treating melasma.
Yes.
So along with sunscreen, there
Um,
should be tutorial should be there. Yes, if there are any other questions, we can take that.
yes. I'm just scanning through the questions. We have few questions. How many months they can use oral transamic once the pigmentation is done for 6 months later, or they should not use oral or not? Sorry, the question framing is a bit off, but did you guys understand the question?
Yes, how long the transamic acid can be used safely?
Yeah.
Anybody can take it, Dr. Pallavi.
Usually, we give it for 3 months of time, and it can be given for 3 to 6 months of time frame.
Okay. But you can give it 4 to 6 months, and it's much lesser than the hemostatic. The dose which we use to treat melasma, it's much lesser than the hemostatic dose, actually. 50 mg BD. And in the other, what the gynecologist use is a much, much higher dose. We should not be, and recently there are a lot of papers in which the safety profile has been proven for more than a year. But what we generally do in clinical practice, we use it for 4 to 6 months, then wait for other 3 to 4 months, and then again reuse for on and off as a cyclical therapy. You can use it for a longer period of time. And it depends on in which age are you using also. Are you using it pre-menopause? Are you using it post-menopause? A lot of factors are there.
Mhm.
We need to read more dermatology about it. Yeah.
Dr. Anna or Dr. Ameesha, if you want to jump in here, otherwise I can move to the next question.
So for tranexamic acid, we can also give a lower dose. So even a dose of 125 milligram works, is what I would like to add. And like Sir mentioned about the gynecological papers. So in gynecological papers, there are also studies which say in higher doses, it can be given up to 2 years also. So the usual protocol that I do is I give 500 milligram for 1 to 3 months, depending on response. Then I taper it down to 250 milligram, and then I maintain at 125 milligram for another 3 months. So good for a period of 6 to 8 months. Then give it a gap, and depending on recurrence, restart it after a gap of 1 to 3 months if needed.
Okay. So that's 125 milligram work to reduce melanogenesis and the vascular component of melasma.
Yes, sir. Actually, there are now papers.
I don't have any experience of this.
No, sir, it works also practically, and now there's some papers also and studies also coming that 125 milligram works.
Okay, done. We'll start using it again. So I think, Melanie, I'll suggest to conclude the program, and that's why it's
Yes.
over to you. It's already, yeah.
So thank you, Dr. Neeraj, for so masterfully moderating this evening's discussion and keeping the conversation both engaging and clinically relevant. A very special thank you to our speaker, Dr. Anna, for joining us all the way from Spain and sharing such an invaluable scientific insights on meline protocol. Your expertise has truly elevated this discussion. We're equally grateful to our wonderful panelists, Dr. Ameesha and Dr. Pallavi, for bringing such rich clinical perspectives and real-world experiences to the table tonight. And most importantly, a heartfelt thank you to each one of our participants for your time, your engagement, and your questions. It is your curiosity and passion for dermatology that makes events like these truly worthwhile. On behalf of Aakaar Medical Technologies Limited, we hope this evening has been as enriching for you as it has been for us. We look forward to continuing this journey together in bringing the best of science-driven skincare to dermatologists across India. Thank you and a good night.
Thank you.
Good night.
Thank
you very
you. Good
much.
night. Thank you so much, doctors.
Thank you so much. I'll conclude with just 3 words. It's dinner time. Thank you.
Yes.
Bye, everyone.
Thank you.
Thank you. Bye bye.
Bye. Thank you so much. Bye, Dr. Anna.